We recently published a paper in the New England Journal of Medicine Evidence that focused on the issue of access to CAR T-cell immunotherapy. CAR T-cell immunotherapy is a highly sophisticated and highly expensive therapy that can be received only on tertiary centers that have been approved for CAR T-cell therapy. And the distribution of these centers is really non-homogeneous throughout the different countries. For example, in the United States, we have a lot of CAR T centers in the East Coast and very sparse centers in the center of the country and also in the West Coast. And so for some patients, it might be difficult to travel to go to a CAR T-cell center. On top of that, based on the healthcare system, there might be issue of access related to the insurance and the cost and so on. There are also other socio-economic or psychological factors that might change and might drive access to a therapy. So, we try to tackle this issue by looking at minority health population, and we use the NIH definition of minority health population, which includes African American, Indian American, and Pacific Islanders as of races and as the ethnicity included the Hispanics, Latinos, Hispanic. And we try to understand if those patients, minority health population, had similar access to CAR T-cell patients, to CAR T-cell therapy as the non-minority health population had. And what we found is that when we were looking at the general population with lymphoma in the catchment area of two cancer centers, one in Philadelphia, so it's a metropolitan, highly populated, minority population-rich area. And we compare it to Portland, Oregon, which is a more rural, it's a city, but the catchment area covers the whole state, so a more rural area with a lower frequency of minority health population. And what we saw is that in our center at the University of Pennsylvania, in the catchment area, we would expect about 17-18% of patients defined as minority health population. And that number was sort of maintained when you look at the patients that were actually treated for lymphoma at the cancer center. So if you look at the catchment area, so all patients in the area around the cancer center, about 17%. You get inside the cancer center, patient with lymphoma, same percentage, similar. But when we then look into a further subgroup, which is the CAR T-cell patient, so lymphoma patient, receiving CAR T-cell patient, now that number went down to about 6%. And so that suggests that there is sort of a selection and there is sort of a limitation to get CAR T-cell therapy from minority population. And so this was true for the African American, Asian, I forgot to mention Asian patient as a minority population, and Indians, American Indians, and Pacific Islander. And the same was for the ethnicity of Latinos and Hispanics. Also, in their case, the frequency was going down. And when we look at this population, minority population, we compare the outcome. The outcomes were pretty similar. So similar toxicity, similar responses. So at least for the patient who did receive CAR T-cell therapy, we could not pinpoint differences in outcome. So again, of course, now the next big step is understanding why are these patients not receiving CAR? What are the main barriers to getting to CAR therapy? Is that the cost? Is that a bias from the doctor, a bias from the patient? Are there other reasons like distance and so on? And so we are working on that because we think it's a very important topic to address.